Doctors, we are live now. You can start the session.
Okay. Shilpi, you can share the screen. So good evening, friends, all the postgraduates and the mentors. Welcome to this Pan-India Intercollegiate PG quiz. This is being done by the Brain Teasers in association with Ophthalmological Society of Nagpur, and it's the big Q back again. Next. So this is
साले को जीतना ही है।
everyone wants to win. You have to fight.
छोड़ छाड़ के सारे छप्पर हट समंदर अपना अंबर खोज ले अब तू अपने दम पर फूक मार के धूल झाड़ ले छोड़ छाड़ के सारे छप्पर खोल दे पर खोल दे पर खोल दे पर खोल दे पर बंद घड़ी की भी रुकी हुई सुई होती सही दो दफा चुप क्यों है रहना मन का तू कहना रोके चाहे हिचकियां खोल दे पर खोल दे पर खोल दे पर.
So once more, good evening, friends, and my pranam to all the mentors. Brain Teaser Teams welcomes you to this 6th episode of the 4th season of Big Q. As you are you are now by aware that Brain Teaser is an online platform which has been hosting quiz for ophthalmologists of our country since last 6 years or seasons, I should say. And it was since last 3 years we have been doing this Big Q, which is an exclusively quiz for postgraduates with the aim of getting all postgraduates from across the country on a single platform. As I shared with you, there are almost 400 plus institutions offering post-graduation in ophthalmology, be it MS and DNB. First season we did with Bombay Ophthalmic Association, and since then, last 2 seasons, we have been doing it with Ophthalmological Society of Nagpur. And we are really thankful to the President, Dr. Krishna Bhojwani, for accepting to be a part of this particular event. This season again had 6 preliminary round, and today is the last preliminary round, and where we will be having the theme is retina and uvea. Following this, we are having 4 quarterfinal. The first of the quarterfinal this time will not be about 14 days later, but it will be 3 weeks later. That is going to be on 9th of April. Then it will be followed by 2 semifinals and then a final. As you remember, the episode are being aired alternate Wednesdays, but for the next one, which will be following All India Ophthalmological Society meeting at Delhi. And so it would be on 9th of April. Just remember that. Brain Teaser is extremely thankful to the team of Quizmaster who toil hard to make a wonderful experience of learning with fun. Today's episode, we have 3 Quizmasters. The first is Dr. Himadri Chaudhary, who is currently working as a consultant retina and vitreous at Chaudhary Eye Hospital and Research Center, Silchar, Assam. Dr. Pooja Negi, who is a consultant in retina unit of MNJ Western Regional Institute of Ophthalmology at Ahmedabad. And a dear friend of mine, Dr. Mudit Tyagi, who is a consultant and head of services at Srimati Kanuri Santama Center for Vitreoretinal Diseases at LV Prasad Eye Institute, Hyderabad. We would be definitely missing Dr. Mudit Tyagi, as his father has undergone an emergency surgery. We wish his father a very speedy recovery. Money maketh a mayor go, and is an old saying, and as such mega projects are not possible without a strong financial support from farmers. So we are extremely thankful to His Highness for accepting to be a partner for this particular season. And my sincere most gratitude goes to Mr. Surya Narayanan, Mr. Naresh, Mr. Kautub, and the entire team of His Highness who has made so much of effort to enroll all the postgraduates from across the country. Smooth and flawless execution of any brain teaser or an online event is possible only because of a hard work from the back-end team, that is from Numerotech, and my sincere thanks to Mr. Sai and his team. So now, without much ado, can I request my co-quiz master, my co-host, Dr. Shilpi, who will also be the today's replacement as a quiz master for one of the few of the questions, to take over the postgraduates to the set of rules and familiarize them with the same. Over to you, Shilpi.
Thank you, sir. So good evening, friends, and welcome back to the last preliminary round of this season of Big Q. So today is the last preliminary round, that is the 6th episode. So let's quickly see what are the rules. You all know that the criteria for qualifying for quarterfinal is the best 4 performances of the last preliminary of the 6 preliminary rounds. So today you have the last chance to perform well so that it can be counted in your best 4 performances. So you need Kahoot platform, and also you need to log in from 2 devices. The first screen is the Zoom platform. Live quizzing will happen on this. And the second screen is the Kahoot platform to answer the questions. I request all the mentors to join in from a separate screen only on the Zoom platform. So today also we'll have 9 sets of MCQs. Each set will have 5 questions and you will get 10 seconds per question, and there is no negative marking. So these are the prizes in the finals for the postgraduates, and for the audience prize, we have prize per episode. So without wasting time, let me introduce our first quizmaster, Dr. Himadri Chaudhary. He has done his fellowship in vitreous retina from LV Prasad Eye Institute. He has been presenting various papers, posters, and videos in international, national, zonal, and state conferences. He was a part of instruction courses on phaco, diabetic retinopathy, endophthalmitis in national and state level since 2015. He's a vitrectomy trainer of SSTC in AIC since 2016. He's a faculty at AIS ARC since 2018 and faculty of DSTC and TSTC courses since 2019. He has won various awards, to name few. He won the gold medal for best medical graduate in 2007, gold medal award for securing first position in MS ophthalmology. He also won the KR Datta award for best paper in OSACON 2018, best video in OSACON 2019, and K. Vengala Rao award in 2020-24 during AIOS APOS. He has more than 10 publications in international and national peer-reviewed journals and is currently working as consultant vitreoretina at Chaudhary Eye Hospital and Research Center, Silchar, Assam. With this, I hand over the screen to Dr. Himadri, sir.
Thanks a lot, Dr. Shilpi, for the kind introduction. We will be directly going on to the questions. Okay. So which cytokine is most associated with granulomatous uveitis and sarcoidosis? Is it A, interleukin-1? Is it B, tumor necrosis factor alpha? Is it C, interferon gamma? Or is it D, VEGF? Your time starts now. We'll move on to the answer. The answer is C, interferon gamma. Well, sarcoidosis is characterized by a Th1 mediated immune response where interferon gamma plays a pivotal role. Tumor necrosis factor alpha also contributes, but it is less specific for sarcoidosis. So moving on, in VKH or Vogt-Koyanagi-Harada syndrome, which is the hallmark of the chronic convalescent state? Is it A, sunset glow fundus? Is it B, a retinal detachment? Is it C, hyperemic disc? Or is it D, anterior uveitis? Your time starts now. Well, the correct answer is sunset glow fundus. So that is why we tell our postgraduate trainees that we have to treat the patient before the patient develops a sunset glow fundus. This is marked by depigmentation of the choroid, and the fundus gets an orange-red appearance, which we call sunset glow fundus. And we see exudative retinal detachment in the acute stage. All right, moving on to the next question. In sympathetic ophthalmia, Dallen-Fuchs nodules are found in which layer? Is it A, choroidal stroma? Is it B, underneath the retinal pigment epithelium? Is it C, in the retinal nerve fiber layer? Or is it D, in the inner choroid. Your time starts now. All right, the correct answer is B, just underneath the retinal pigment epithelium. So Dellenfuch nodules are granulomas which contain lymphocytes and epithelioid cells, and they are situated between the retinal pigment epithelium and the Bruch's membrane. They are seen both in sympathetic ophthalmia and in VKH. All right, moving on to the next question. In Fuchs heterochromic iridocyclitis, the typical finding on gonioscopy is A, peripheral anterior synechia. Is it B, posterior synechia? Is it C, fine angle vessels without synechia? Or D, angle recession? Your time starts now. Well, the answer is fine angle vessels without synechia. C. In heterochromic iridocyclitis from Fuchs, there is angle neovascularization, which rarely leads to peripheral anterior synechia, and it is a very unique feature in Fuchs heterochromic iridocyclitis and among inflammatory glaucomas. Moving on to the next question. What is the most common mutation associated with uveal melanoma? Is it A, GNAQ? Is it B, BAP1? Is it C, MYC? Or is it D, RAS? Your time starts now. Well, the correct answer is GNAQ. So mutations in GNAQ and GNA11 are early events in the uveal melanoma development, and they promote melanocyte proliferation via the MAPK pathway. BAP1 mutations are associated with metastasis and poor prognosis, but the most common is GNAQ. All right, moving on. So I'll introduce Dr. Pooja Negi. She has done her MBBS DOMS from Baroda Medical College and is working as a consultant in retina unit of M&J Western Regional Institute of Ophthalmology, Ahmedabad since 2008. Her special interest is in uveitis. She is co-investigator in various trials of wet ARMD and diabetic macular edema, and is a student at heart with passion for teaching the mysteries of retina to junior residents and the art of vitrectomy to seniors. Over to you, Dr. Pooja.
Thank you, Dr. Himadri. And thank you, Dr. Prashant sir, for giving me this opportunity, and Dr. Shilpi for all her hard work. So we begin with the first question. All are treponemal tests for syphilis except your options are A, FTA absorption test, B, VDRL, C, ELISA, and D, TPHA. Your time starts now. And the correct answer is B, VDRL. VDRL and RPR are non-treponemal tests for syphilis. The rest are treponemal tests. Non-treponemal tests detect antibodies that are reactive to lipoidal antigens shared by both host and Treponema pallidum, while the treponemal tests detect antibodies which are specific to Treponema pallidum. Both the tests must be used in conjunction to help distinguish between untreated infection or treated past infection of syphilis. Nowadays, with the resurgence of syphilis, it is to be done in all patients of uveitis. Next question. All are causes of abnormal hyporeflectivity on optical coherence tomography, except your options are A, retinal edema, B, hard exudates, C, subretinal fluid, and D, sub-RPE fluid. Your time starts now. And the correct answer is B, hard exudates. Abnormal hyporeflectivity on OCT could be due to fluid in the retina, in the subretinal space, or in the sub-RPE space. Abnormal hyperreflectivity can be due to hard exudates, calcification, hemorrhage, fibrosis, choroidal membrane, ERM, RPE hyperplasia, and vitreous membranes. Next question. Classical triad of acute retinal necrosis includes all except your options are A, necrotizing peripheral retinitis, B, optic atrophy, C, moderate to severe vitritis, and D, occlusive vasculopathy mainly involving arteries. Your time starts now. And the correct answer is B, optic atrophy. Optic atrophy, scleritis, and pain are the supporting clinical criteria for acute retinal necrosis. Bilateral ARN is known as BARN. Acute retinal necrosis typically occurs in immunocompetent individuals. It is usually caused by the herpes virus family. Most common is the VZV virus. Treatment consists of IV acyclovir or oral well acyclovir. It is one of the ocular emergencies, and retinal detachment occurs in 75% of ARN within 3 months. Next question. Dislocated intraocular lens in the vitreous and choroidal detachment are shown respectively in fundus charting in, your options are A, blue and green color, B, red and blue color, C, green and brown color, and D, brown and red color. Your time starts now. And the correct answer is C, green and brown color. This is the international color coding for fundus charting. Anything in the vitreous, be it the Weiss ring, a vitreous haze, asteroid hylosis, dislocated IOL is shown in green color, while the choroidal detachment is shown in brown color. Next. Identify the disease and the investigation based on the below image. Your options are A, multifocal CSR and fundus fluorescein angiography, B, stippled CNVM and ICGA, C, serpiginous-like choroiditis and fundus autofluorescence, and D, multiple evanescent white dot syndromes and fundus autofluorescence. Your time starts now. And the correct answer is C, serpiginous-like choroiditis and fundus autofluorescence. Fundus autofluorescence is the go-to modality for follow-up of patients with serpiginous-like choroiditis. In the stage 1, the lesions appear in the acute stage as an ill-defined diffuse halo of hyperautofluorescence. In stage 2, when they reach the subacute stage, there is a thin hypoautofluorescent rim at the border of the lesion, which becomes more hyperautofluorescent. In stage 3, there is a stippled pattern in FAF as the central hyperautofluorescence decreases and the peripheral hypoautofluorescence increases. And in stage 4, when the lesion has scarred completely, there is generalized hypoautofluorescence. It is a proud moment for me to introduce Dr. Mudit Tyagi, as he has done his residency training from our institute, BJ Medical College, Ahmedabad, in 2010. He has done his VR fellowship from LV Prasad Eye Institute, Hyderabad, in 2012, and presently he is the consultant and head of services at Srimati Kanuri Santama Center for VR diseases at LV Prasad Eye Institute, Hyderabad. His areas of interest are VKH, ocular syphilis and ocular inflammation, endoscopic retinal surgeries, VR surgeries in uveitic disorders, fibrin glue in retinal surgeries. He has 150 publications in peer-reviewed journals. He has, to his credit, honor and achievement awards from the American Society of Retina Specialists. He has won the Best Video Awards at ASRS and URetina. He received the Best Innovation of the Year award from VRSI for his work on fibrin glue in retinal detachments. And he won the Krasik Award in ARVO for excellence in retinal surgeries.
So as sir is not there, so I'll take over his questions. So the set 3, first question is, 7 rings of trauma include all except option A, angle recession, B, sphincter tear, C, iridodialysis, and option D is Berlin's edema. And your time starts now. Time is up. And the correct answer is Berlin's edema. Berlin's edema is not included in 7 rings of trauma. Moving on to the next question. Alport syndrome consists of all except A, anterior lenticonus, B, pigmentary retinopathy, C, giant macular hole, and option D, giant retinal tear. Your time starts now. The correct answer is giant retinal tear is not a feature of this syndrome. Moving on to the next question. What does the subtenon fluid, that is T sign, on ultrasound most commonly indicates? Option A, is it retinal detachment? B, posterior scleritis? C, posterior vitreous detachment? D, chorioretinitis. Your time starts now. Time is up and the correct answer is posterior scleritis. T sign is also seen in panophthalmitis. So moving on to the next question. HLA-B27 associated anterior uveitis is typically characterized by which of the following features? Option A, is it bilateral granulomatous anterior uveitis? Option B, it is a unilateral alternating non-granulomatous anterior uveitis, often associated with systemic inflammatory conditions. Option C, alternating bilateral granulomatous anterior uveitis with a prodrome. And option D, unilateral granulomatous anterior uveitis. And your time starts now. So the correct answer is, it is unilateral alternating non-granulomatous anterior uveitis, and it is often associated with systemic inflammatory conditions. So the last question of this set is, which of the following are signs which are suggestive of viral anterior uveitis? Option A, fine capes, posterior pars and iris nodules. Diffuse pigmented granulomatous capes, iris atrophy or raised IOP. Non-granulomatous capes, iris nodules and D-shaped pupil. And option D is raised IOP and pars. Your time starts now. Time is up and the correct answer is option B. If you get diffuse pigmented granulomatous keratic precipitates with iris atrophy and raised intraocular pressure, then there is more chances that this is viral anterior uveitis. So with this, I end this section and I invite again Dr. Himadri sir for the next set of questions.
Moving on to the next set. In diabetic retinopathy, which enzyme is primarily responsible for VEGF upregulation? Is it A, aldose reductase? Is it B, protein kinase C? Is it C, sorbitol dehydrogenase? Or is it D, glucose 6-phosphate dehydrogenase or G6PD? Your time starts now. Time up. The correct answer is B, protein kinase C. So hyperglycemia, which activates protein kinase C, stimulates VEGF production and leads to vascular permeability, neovascularization, and subsequent diabetic retinopathy. Hence, there have been a lot of research molecules which have targeted this protein kinase C. All right, moving on to the next question. Which imaging modality is most sensitive for detecting small choroidal melanomas? Is it A, fundus fluorescein angiography? Is it B, optical coherence tomography or OCT? Is it C, ultrasound B scan? Or is it D, ICG angiography? Your time starts now. Time up. And the correct answer is C, ultrasound B scan. Ultrasound B scan is highly sensitive in detecting and differentiating small melanomas from benign lesions like nevi. It measures the tumor's height and detects acoustic hollowness. Moving on to the next question. In age-related macular degeneration, geographic atrophy is associated with loss of, is it A, retinal pigment epithelium? Is it B, photoreceptors only? Is it C, retinal ganglion cells? Or is it D, retinal vasculature? Your time starts now. Time up. And the correct answer is retinal pigment epithelium, A. So, as we know, in geographic atrophy, in dry AMD, it involves atrophy of the retinal pigment epithelium, underlying choriocapillaries, leading to photoreceptor degeneration and a permanent vision loss. All right. The hallmark of finding in fundus autofluorescence imaging in vitally form of Best disease is it A, hyperautofluorescence? Is it B, hypoautofluorescence? Is it C, bullseye pattern? Or is it D, patchy peripheral autofluorescence? Your time starts now. Time up. And the correct answer is A, hyperautofluorescence. So as we know, in the vitally formed stage, there is a hyperautofluorescent lesion in the macula. It correlates with lipofuscin deposition in the RPE. In acute retinal necrosis, the most commonly implicated viral agent is it A, herpes simplex virus, HSV1? Is it B, varicella zoster virus? Is it C, cytomegalovirus? Or is it D, Epstein-Barr virus? Your time starts now. Time up, and the correct answer is B, varicella zoster virus. So varicella zoster virus is the leading cause of acute retinal necrosis. As Madam mentioned, it happens in immunocompetent patients. It is characterized by peripheral retinal necrosis, vasculitis, and without a prompt treatment, it leads to a poor visual prognosis. So with this, we move on to the next set of questions by Dr. Pooja.
Okay, we'll start with the first question. What is the spot diagnosis based on the ultrasound picture? Your options are A, optic nerve melanocytoma, B. Optic disc drusen, C. Papillitis, and D. Disc edema. Your time starts now. And the correct answer is B. Optic disc drusen. So disc drusen is a small collection of hyaline material in the nerve head. Most patients remain asymptomatic, so they are detected on routine examination. Superficial drusen are identified easily on the fundus examination, but buried drusen require examination ancillary to diagnose and to differentiate from disc edema. The B scan will show calcification within the disc area as a hyperechoic spot, and the drusen will show hyperautofluorescence on fundus autofluorescence. Next question. The flying saucer sign on OCT is seen in which condition? Your options are A. Hydroxychloroquine retinopathy, B. Sickle cell retinopathy, C. Atrophic macular dystrophy, and D. Posture's retinopathy. Your time starts now. And the correct answer is A. HCQ retinopathy. Hydroxychloroquine is used in rheumatology and dermatology. Its side effects on the retina are irreversible. It causes destruction of macular rods and cones with sparing of the foveal cones. So this gives the classic flying saucer sign on OCT, which describes perifoveal loss of the ellipsoid zone with preservation of photo the subfoveal region. A complete ophthalmological examination before starting the drug and annual screening after 5 years with visual field and OCT is recommended. Next question. Which drug was studied in the Yosemite and Rhine trials? Your options are A. Bevacizumab, B. Brolucizumab, C. Faricimab, and D. Ranibizumab. Your time starts now. And the correct answer is C. Faricimab. Yosemite and Rhine are identically designed phase 3 clinical trials of faricimab in treatment and previously anti-VEGF treated patients with center involving DME. The effect of VEGF and angiotensin 2 is thought to have a longer lasting effect than the previous anti-VEGF agents in clinical trials. It is given as an intravitreal injection at the dose of 6 mg from 0.05 ml of a 120 mg per ml solution. What is a biological product highly similar to the no clinical meaningful differences in safety? A. Biobetter, B. Biomimic, C. Biologic, and D. Biosimilar. And your time starts now. And the correct answer is D. Biosimilar. So, biologics are medicines, active drug substance of which is made by or derived from a living organism using recombinant DNA technology with controlled gene expression. Biobetters or me-betters are new, highly differentiated and potent biosuperiors based on an existing approved biologic. A biosimilar is a biological product which is highly similar to the approved innovator product with no clinically meaningful differences in safety, purity, and potency. Biosimilars offer relatively less expensive, widely available, and affordable treatment options, and so they improve the access to care. Biomimics are unregulated non-parabiologics which fortunately have withered away. Next question. The Kestenbach index is used to diagnose. Your options are A, macular edema, B, optic atrophy, C, disc drusen, and D, macular hole. Your time starts now. And the correct answer is B, optic atrophy. Next slide. Kestenbaum capillary number index is defined as the number of capillaries observed on the optic disc. The normal count is approximately 10. In optic atrophy, the number of the capillaries reduces to less, and more than 12 suggests a hyperemic disc.
With this, we move on to the next set, that is set 6. So the first question is, angioid streaks are most commonly associated with all of the following systemic conditions except. Options are option A, pseudoxanthoma elasticum, option B, Ehlers-Danlos syndrome, option C, Paget's disease, and option D, sarcoidosis. Your time starts now. Time is up. And the correct answer is sarcoidosis. So we see angioid streaks with pseudoxanthoma, Ehlers-Danlos, and Paget's, but not with the sarcoidosis. Next question is, all of the following are features of high-risk proliferative diabetic retinopathy except option A, it's neovascularization of the disc more than 1/3 to half of the disc area. Option B, presence of pre-retinal or vitreous hemorrhage. Option C, moderate retinal neovascularization not involving the disc. And option D, neovascularization elsewhere with the vitreous hemorrhage. And your time starts now. Time is up. And the correct answer is option C, that is moderate retinal neovascularization not involving the disc. Remember, this is a very important question. If you get any case of diabetic retinopathy in your exams, this question is usually asked by every examiner. So next question is, 45-year-old male presents with a sudden shadow in his lower visual field in the left eye. While the fundus examination reveals a retinal detachment, now based on the Linkoff's rule, what is the most likely location of the primary retinal break? Your options are option A, it should be on the nasal side at 7 o'clock position, or it should be at temporal side at 5 o'clock position. Option C is nasal side at 5 o'clock, and option D is temporal side at 7 o'clock. Your time starts now. Time is up. And the correct answer is A, that is nasal side at 7 o'clock position. Moving on to the next question. Cherry red spot is seen in all of the following conditions except option A, central retinal artery occlusion, option B, Tay-Sachs disease, option C, Sandoff disease, and option D, Hurler's syndrome. And your time starts now. Time up. And the correct answer is Hurler syndrome. Moving on to the last question of this set. Which of the following genetic associations is most strongly linked with the development of Behçet's disease? Your options are option A, HLA-A2, option B, HLA-B27, option C, HLA-B51, and option D is HLA-DR3. Your time starts now. Time up. And the correct answer is HLA-B51, which is the most common genetic association which is strongly linked with the Behçet's disease. So with this, we end with the 6 sections of today's episode, and it is time for the commercial break. So this is a small promo from the His Highness team.
So His Highness once more for being a part of this particular.
Now I again invite Dr. Himadri sir for set of questions in set 7.
All right, moving on to set 7. Which of the following is the most common genetic mutation associated with autosomal dominant retinitis pigmentosa? Is it A, mutation in the RHO gene? Is it B, deletion in the CHM gene? Is it C, mutation in the GUCY2D gene? Or is it D, polymorphism in the VEGF-A gene? Your time starts now. Time up. And the correct answer is A, mutation in the RHO gene. The RHO gene encodes for rhodopsin, a key protein in rod photoreceptors. Mutations in this gene are a common cause of autosomal dominant retinitis pigmentosa. On to the next question. All of the following HLA phenotypes are associated with uveitis except, is it A, HLA-B27? Is it B, HLA-B5? Is it C, HLA-BW54? Or is it D, HLA-DR10? Your time starts now. Time up. And the correct answer is HLA-DR10. So HLA-B27, as you know, is associated with reactive arthritis, previously known as Reiter syndrome. HLA-B5 or 51 associated with Behçet's. HLA-BW54 associated with glaucomatocyclitic crisis. And HLA-10 or DR10 is not associated with uveitis. It is associated mostly with lichen planus. Moving on to the next question. Busaka's nodules, A, are a feature of non-granulomatous uveitis. B, are situated at the pupillary border. C, usually initiated posterior synechiae formation. Or is it D, consists of lymphocytes, plasma cells, epithelioid, and giant cells? Which is the correct statement? Your time starts now. Time up. And the correct answer is D, consists of lymphocytes, plasma cells, epithelioid, and giant cells. They are a feature of granulomatous uveitis. As you know, Koppes nodules are closer to the pupillary border. Busaka's are away. And usually they are not associated with posterior synechiae formation. All right, moving on to the next question. Melanoma of the choroid, following histologic features, has the best prognosis. Is it A, epithelioid cell melanoma? Is it B, spindle A melanoma? Is it C, spindle B melanoma? Or is it D, mixed cell melanoma? Your time starts now. Time up. And the correct answer is spindle A melanoma. So we have to know which of them have the worst and the best prognosis, especially for MCQs. Epithelioid melanoma, where more than 90% epithelioid cell has the worst prognosis, and spindle cell melanoma, where more than 90% of spindle cells has the best prognosis. Mixed type has an intermediate prognosis. All right. On to the last question in this group. The earliest symptom of sympathetic ophthalmia is it A, pain? Is it B, decreased distant vision? Is it C, photophobia? Or is it D, diplopia? Your time starts now. Time up. And the correct answer is C, photophobia. So sympathetic ophthalmia, as you know, develops in the other eye, in the better eye. And photophobia is one of the earliest symptoms. So you have to be very careful and ask this patient specifically of any symptoms in the better eye. All right. Moving on to the next set with Dr. Pooja.
Thank you, Dr. Himadri. Now we start with the first question of this set. A starry sky appearance of FFA is seen in, your options are A, central serous chorioretinopathy, B, Vokoyanagi-Harada disease, C, choroidal neovascular membrane, and D, serpiginous-like choroiditis. Your time starts now. And the correct answer is B, VKH. In the early form of the disease, multiple pinpoint areas of leakage are seen at the level of the RPE. This appears as a starry sky on FFA, which is highly suggestive of VKH syndrome. And the late frames of the angiogram show large confluent areas of leakage and late leakage of the disc. Next. Hard exudates are seen in the following, except your options are A, hypertensive retinopathy, B, diabetic retinopathy, C, leukemic retinopathy, and D, exudative retinopathy of course. Your time starts now. And the correct answer is C, leukemic retinopathy. Next question. Dot and blot round retinal hemorrhages are situated at the level of, your options are A, ganglion cell layer, B, nerve fiber layer, C, inner plexiform layer, and D, outer plexiform layer. Your time starts now. And the correct answer is D, outer plexiform layer. Next question. The area of the retina where the ganglion cell layer, inner nuclear layer, and outer plexiform layer are thickest is, your options are A, fovea, B, paraphobia, C, area centralis, and D, periphobia. Your time starts now. And the correct answer is B, paraphobia. Last question. In cystoid macular edema, fluid collects in the macular region at the level of? Your options are A, outer nuclear layer, B, outer plexiform layer, C, inner plexiform layer, and D, between the pigment epithelium and the neurosensory retina. Your time starts now. And the correct answer is B, outer plexiform layer. Over to you, Dr. Shilpi.
Thank you, ma'am. So this is the last set of today's episode and also the last set of this preliminary rounds. So next coming up is the first question of set 9. Retinoblastoma arises from option A, layer of rods and cones. Option B, layer of bipolar cells. Option C, ganglion cell layers. And option D, cone precursors. And your time starts now. Time is up. And the correct answer is cone precursors. So these are the human retinal progenitor cells which give rise to 7 distinct cell types. And retinoblastoma, it develops specifically from differentiating cone precursors owing to the molecular circularity in these cells, which includes high expression of NMYC, SKP2 and MDM2 proteins. So this expression pattern permits the cells to proliferate and undergo a cancerous transformation when the tumor suppressor protein RB is lost. Moving on to the next question. Which one of the following about Coats disease is true? Your options are: it is usually bilateral, it is associated with microophthalmia, it has bimodal age distribution, and the option D is it's equally common between the males and the females. And your time starts now. Time is up. And let's see what is the correct answer. The correct answer is it has bimodal age distribution. So moving to the next question. In which of the following conditions are hard exudates least likely to be seen in? Option A, hypertension. Option B, toxemia of pregnancy. Option C, SLE. And option D, is it Coats disease? And your time starts now. So now let's see what is the correct answer. The correct answer is toxemia of pregnancy. In this, the hard exudates are least likely to be seen. So the second last question is, what is the approximate incidence of post-intravitreal injection endophthalmitis? Your options are: option A, it is seen in 1 in 2,500 cases, or 1 in every 5,000 cases, C, 1 in 7,500 cases, or option D, 1 in 10,000 cases. And your time starts now. Time is up. And the correct answer is option A, that it is seen in every 2,500 case, in one case. So the reported incidence is between 1 in 2,000 to 1 in 3,000. Moving on to the last question of today's episode. This layer represents the junction between the photoreceptor inner and outer segments. So you have to answer between V, W, X, Y, and Z. And your options are: option A, it is Z, option B, X, option C, V, and option D, W. And your time starts now. So the layer which represents the junction between the photoreceptor inner and outer segments is X, which is marked X in the diagram. So with this, we end with the today's quiz. Thank you, Usha ma'am and Himadri sir.
Thank you, Dr. Shilpi, wonderfully conducting the quiz, as well as both the quiz masters, Dr. Pooja and Himadri. Dr. Shilpi had to take over in the absence of Dr. Mudit Tagi, whose father was indisposed, and so he could not join us. Thank you, Shilpi, for taking over so well. Thank you, Suryanarayan sir, for joining us for this last part of the event. We will be having some preliminary talk. So, Sai, are we ready with the finalist of the private practitioner category, or you would need some more time?
2 minutes, doctor.
2 minutes.
I want to say something, that the results of the teams who have qualified for the quarterfinals, we need 1 week time. So by the next week, we will declare the results.
So how would they be intimated? Let them know.
On the WhatsApp group, and also we will send the individual mails.
So all the participants, just remember, we are through with all the preliminary rounds. Based on your performances, top 4 performances, we will decide who are going to be the quarter finalist. The list of the quarter finalists will be displayed on the WhatsApp group, as well as that's it, Shilpi?
No, no.
Individual.
As well as individually, you will be
Individual
intimated. And the first quarterfinals, once more, let me remind you, it will be after the All India Ophthalmological Society. Because of All India Ophthalmological Society meeting on 9th, we will be having it on 16th, the first quarterfinal.
Sir, no. The meeting is on.
Sorry, 9th. 9th.
Yeah.
So 9th of April, we will be having at the same time. And it will be a different set. So very good. That's great, Sai and Numerotic team, for being so fast. These are the 3 people who have topped into the private practitioner category. And their mobile numbers are 8447877573. Can you raise your hand so that we can invite you on the Zoom platform for a small discussion and a small chat? Then the other second number is 83680822207. That is seed again. And the third one is 8597993902. So please raise your hand so that you can join us for a small chat before we wind up today's episode. And the quiz masters also, please do join in. We will have some routine chat with these guys who have topped into the private practitioner category. Yes, Dr. Pooja and Himadri, you can also log in. Want your video on. So, Dr. Pooja, this was your first episode with us. What was your experience?
Sir, I took part last year also.
Second year. Yeah. Himadri has been with us consistently for last so many seasons. So, do you find any difference?
It's getting better every year, sir.
Thank you. Thank you. So, I think I see Q over there. Q.
Good evening, sir.
Good evening. Can you just introduce yourself for the sake of all the viewers?
I am Dr. Q Mondal, senior resident from AIIMS Raipur.
Okay. Good.
Unshare the screen.
Yes, can you unshare? So you are through with your MS?
Yes.
Sir, in last episode also, he was one of the winners.
I know. Raipur team is already, Raipur AIIMS is always there in our final, almost up to finals.
Last time I have participated as a finalist in PG category.
I know. So Dr. Ankur is your role model, or who is your role model there? Or Dr. Somen Mishra, sir?
All faculty members.
Okay, good. So which subject you are specializing in? Dr. Pooja, you can join in with a chat with this winner for today's episode. You are specializing in any specialty, or
in AIIMS Raipur, senior resident actually comprehensive, unit-wise rotation in per year.
Okay, good. So aiming to be retina specialist like Dr. Himadri, or a UVS specialist, or what? Or a glaucoma?
Like oculoplasty, sir.
Really? I know you have been seriously under the influence of your Dr. Ankur, I believe. Dr. Ankur Srivastava is a faculty there, and he is an oculoplasty surgeon and doing phenomenal work in that region. I know.
Yes, sir.
So congratulations, Q, for this wonderful You
Thank
will
you,
be
sir.
getting your prize money from His Highness team at the conclusion after all these episodes. So once more, keep playing, keep encouraging other students also, and get them enrolled more. Thank
Thank
you.
you so much, sir.
Congratulations, Doctor.
Congratulations.
Thank you. Do we have anyone else, Sai, with us?
The usual winner, Dr. Panchami Gupta, raised her hands, but she's not joining as a panelist now.
Okay. Dr. Panchami, where are you?
She thought we will pull her again.
She's running away. Okay. And the third one?
I think Dr. Vineet.
Are they with us?
No, Doctor, they haven't joined.
Okay, no issues, no issues. So friends, we had a wonderful session today on retina and uvea. We are really extremely thankful to Himadri, Dr. Pooja, and of course, Dr. Mudit Tagi. It was a wonderful experience for all of us, not only just science, but also some fun with it. And of course, Surya Narayan sir, your concluding remark before we wind up.
Doctor, as always, I would like to thank you and your team for helping us with this opportunity to support this academic initiative. And congratulations from Team His Highness for all the winners up till now.
Thank you, thank you.
Welcome,
Thank
Doctor.
you.
Welcome. Thank you. Thanks a lot.
Thank you, Surya Narayan sir, for being with us in this season. And I'm sure we will continue, our association will continue in future seasons as well. Okay.
100%, Doctor.
Thank you. Thank you so much.
Thanks a lot.
So,
Thanks a lot.
Dr. Pooja, Dr. Himadri, once more, sincere most thanks for contributing to
Thank
Brain
you, sir.
Teasers, and welcome
Thank
again.
you,
And
sir.
we would be expecting you to be contributing to us in the following seasons as well.
Sure, sir.
We look forward to your, in fact, a very positive intent, and we are very happy with that. We will be looking forward to your associations in future as well. So without much ado, now it's time for us to say goodbye from our end. Dr. Shilpi, once more, sincere thanks for taking over and compensating the absence of Dr. Mudit, and Dr. Pooja and Dr. Himadri. Thank you once more for making it such a wonderful show. And Sai, thank you for computing the results and running the whole back-end office so well. Thank you once more. And
Thank
so,
you.
Thank you all.
postgraduates,
all.
we are meeting now on 9th of March, 9th of April at 7:30 p.m. at the same time. Remember, the teams which are making it to quarterfinal will be logging in and playing that episode. The people who are into quarterfinal 2, 3, 4, please do participate as a private practitioner category on that day, so that you get the feel of how the level of the quarterfinals is going to be, and it will be a further learning experience for you as well. So keep playing. So only quarterfinal teams, which will be we will be letting you know by next week, will be participating in that so that they compete for the semi-finals. So till then, it is time for us to wind up from our say bye-bye from our end. Thank you. Thank you everyone
Thanks.
once.
Thanks a
Bye-bye.
lot.
Thanks a lot, sir.
Thank you, Surya Narayan
Thanks
sir.
a lot.
Thanks
Thanks a lot.
to all doctors. Thank you. Thanks a lot.
Thank you.